Shuvro Roychowdhury. Let's have his talk going. So Shuvro is a friend and colleague who practices in Kolkata. So let's have his presentation on.
Oh, hi there. Good morning and good afternoon. This is Dr. Shuvro Roychowdhury, and I'm going to talk today about the radiology in groin hernias. And the first question we need to ask ourselves is that why are we as radiologists here? I would like to address two questions in this presentation. The first is that is there a hernia, and if so, is it a direct, indirect, or femoral hernia? The reason why we question ourselves is that inguinal hernia diagnosis can be confirmed by physical examination alone in the vast majority of patients. Rarely you would use an ultrasound, or less commonly still a dynamic MRI or CT scan or even a herniography to make a diagnosis. Of course, imaging is more useful in other hernia areas. The imaging modalities that we can use are ultrasound, CT and MR, and the advantages and disadvantages are listed here. Ultrasound, of course, is non-ionizing, it is dynamic, it is cheap, it is available. But on the other hand, it is not so good in obese people. It is not so good to assess what content the hernia has. It cannot see through deeper tissue, and it is operator dependent. CT, of course, is excellent, highly effective. It is best for the acute setting. It is also very good in sorting out the various hernia types, as we would see later on in the talk. It does look into the entire wall and the cavity. It is multiplanar, however, it uses ionizing radiation. MRI is a mix of the best of both ultrasound and CT. It can be dynamic, it can be, Valsalva can be done, it is multiplanar. A lot of other pathologies like groin strain related pathologies can be detected with MR. But it is slightly expensive, maybe not so more nowadays. That leaves us with this test called herniography, which is something that we don't perform as often nowadays. We used to do quite a lot of these in our UK younger days, and it is not as invasive or as bad as it is made out to be, and it is highly accurate, as we would see later. Before we get into the ins and outs of CT and MR, just a quick revision of the anatomy of the inguinal region, and here is the pectineus, which is an important muscle. Here is the obturator externus and the obturator internus. This is the obturator space. This just medial to the femoral vessels on this side is the femoral canal containing the femoral hernia. We will talk about the inguinal hernia coming here, and an obturator hernia comes here. So these are the important spaces to be aware of. Just to get the rear one out of the way, this is an obturator hernia, thickened bowel wall, bowel as a content causing upstream small bowel obstruction. This is quite an old scan, and here is the pectineus muscle. So behind the pectineus is the obturator hernia. Coming to the inguinal anatomy, I mean, we know this from the surgical literature. We have the external iliac vessels coming down as the femoral vessels. We have the inguinal ligament, the lacunal ligament, the femoral canal somewhere here, and here the inferior epigastric vessels. And we know that this is something that forms a boundary of the inguinal triangle, and it divides the space for the direct, for the indirect and the direct hernias. And here is the deep ring and the superficial ring. Now the inguinal canal is not in plane on a CT scan, but all these other landmarks that I talked about is visible on CT scan. The traditional surgical teaching is that an inguinal hernia is above and medial to the pubic tubercle, and the femoral hernia is below and lateral to the pubic tubercle. But we are all taught this. But there are problems with this, both as a surgical trainee and subsequently as a radiologist. And there are some surgical papers now that are questioning this little content. And for example, this particular paper talks about inguinal hernias, 97% of them have their necks above and lateral to the pubic tubercle. So femoral hernias, of course, have their neck below and lateral. So the only way to distinguish inguinal and femoral is whether they're above or below the pubic tubercle rather than medial or lateral. And this is somewhat similar to this, quite a nice paper that talks about these lines on an axial CT image, and this is something that I use in my day-to-day practice. You draw an X line along the anterolateral point of the pubic tubercle, horizontal line, and two vertical lines like so. And if you draw these three lines, then an indirect hernia is always lateral to the Y line. The direct hernia often transects the Y line, and a femoral hernia is always behind the X line. If you use this, you've got quite a high concordance with surgery. There are of course some other softer findings, for example a hernia sac coming out effacing the sac like so. It's called the lateral crescent sign, of course remaining medial to the epigastric vessel. So once again, this is the lateral crescent sign of a direct hernia. And here is a little movie of a recent case of an 80-year-old gentleman with right-sided abdominal pain who has a hernia, and it was conceived by the younger surgeons that this could be the cause. And here we can see the hernia. And one thing I would just like to point out to you is the epigastric vessel just coming here. And this sac is medial to the epigastric vessels, and therefore it is a direct inguinal sac. And you also saw a little the lateral crescent sign. Now, these are the various reformats you can do, and this is the beauty of CT. You can see the sac, you can see the content, you can see the size of the defect. And actually, I don't want to concentrate on this, but basically, this patient has a thickened appendix base at some soft tissue thickening of the cecum, has got a cecal cancer with the secondary appendicitis and stranding as the cause of this patient's acute presentation and not the hernia. A indirect hernia sac, on the other hand, is lateral to the epigastric vessel. And you can use the X line like I described. So indirect hernia, direct hernia, femoral hernia, inguinal ligament. So a femoral hernia, once again, femoral nerve, artery, vein, and the femoral canal containing the Clockett's lymph node and some fat. And here is where the femoral hernia sac will come below the inguinal ligament. As you can see, below the inguinal ligament, the sac is coming like that. And as I said about the X line, it is always behind the X line, the sac is. Femoral hernias are well seen on ultrasound predictably, and here is the femoral artery, the vein, and this is the femoral canal, and you can see that on a Valsalva there is some fat coming out in an abnormal patient as opposed to a normal patient where you can see a hernia. Coming to occult hernias, these were largely about obvious hernias. Coming to occult hernias, you can do something called a resting and a straining scan, both with CT, MR and ultrasound. Now, we do this often in a prone position, and I usually do MR. I couldn't locate my MR images with lockdown stuff going on and stuff like that. This is one borrowed from the internet, but very quickly you can see this bulge. Now, I am also always not sure that when to call this a hernia, how far is the bulge called a hernia and not a hernia. I think a clear communication with the surgical team is really useful here. So just very briefly reviewing the literature of the various modalities in diagnosing these hernias. If you compare ultrasound, CT and MR, MR is taken to be the most definitive radiological examination. This is a rather interesting paper talking about inguinal hernia diagnosis with CT using prone versus supine position, and 79 cases, 87 operated lesions, and 71 non-operated lesions, so fairly large number of cases. And if you look at the results, what basically they talk about is that prone CT detects more occult hernias and is also at least as good in detecting what type of hernia it is. So prone CT acquisition alone is adequate for detecting and classifying inguinal hernias and for evaluating occult hernias. Ultrasound is good, in good hands. It is very good. Dynamic inguinal ultrasound, fantastic, high sensitivity and specificity. But if you look at a systematic review and meta-analysis of the role of radiology, they talk about comparing MR, ultrasound and herniography. And they talk about herniography having the highest sensitivity of 91%, although of course this is not as much performed nowadays. So herniography has a higher sensitivity and specificity than even MR according to this study. Now this is an interesting study that is comparing groin hernia with physical examination, ultrasound, MR comparing to laparoscopic gold standard. And what they found here too, that actually MR is better both in terms of sensitivity and specificity compared to physical examination. So it adds more cases. So there is a logic in performing MR in physically examination naive patients for hernia. Just a quick borrowed picture from the internet. My pictures, several computers have changed since those pictures were saved. But these are the sac, as you can see, and you can see some the protrusion, and judging by the pubic tubercle, you can talk about whether they are femoral or inguinal. So here is a quick protocol, I think roughly talking about the same things that we just outlined. If you have a high clinical suspicion of inguinal hernia and your diagnostic examination, and it's a good physical examination, doing a proper Valsalva, the patient is walking and then you're examining after Valsalva, etc., then please proceed to do a repair without any imaging. You can add a little ultrasound to reinforce your diagnosis. But if it is a non-diagnostic or a hidden hernia, if you can do an MR, then please do so. But if you can't do an ultrasound or CT, but if that is negative, please do an MRI before you say that this patient does not have an hernia. Of course, CT is the best imaging modality in terms of diagnosing an acute situation like incarceration or obstruction, because not only does it diagnose or detect the hernia, it also talks about the degree of obstruction, whether there is bowel ischemia, strangulation, all of that. The differential diagnosis, when a patient is sent to you with a groin swelling, it is important to remember that in addition to a hernia, you can have lymph nodes, encysted hydrocelular cord, things like undescended testis or round ligament varicosities, etc. It is just important to remember the differentials when you're performing the imaging. Now I'm just going to spend the last few minutes talking about some post-operative appearance and after an inguinal hernia repair. Now this is not something that we do very frequently. These images are actually borrowed from this wonderful paper, and this table is borrowed from there too. And basically focal protrusions or pseudolesions, we'll talk about these very briefly. We won't talk about these two, epiploic appendicitis and omental infarctions, which can be associated causes of pain after hernia repair. But whether it is an open repair or a laparoscopic Liechtenstein or a TAP or a total extraperitoneal repair, it is important to know how it was done before you consider reporting these scans. So here is a standard post-operative appearance, and you see a little fatty area. You see the location of the mesh. You don't see the tacks anymore nowadays as much as in the past, but this is the sort of typical post-operative appearance, and this will resolve over time. A little bit of thickening of the spermatic cord, a little bit of stranding like this is common, thickening again of the spermatic cord. These would resolve over time. A little bit more than that, the stranding extending right the way to the scrotum. This will take some time to resolve, but even these don't need re-exploration. You can sometimes have a little rounded area of stranding, particularly with a plug mesh. Again, this is also something that would resolve over time. As opposed to a seroma, which is not as common as an incisional hernia repair, but it's still seen. An ultrasound is very good in characterizing the seroma, whether this is benign, whether it's septated or not, and these can be aspirated or drained. An abscess also, thick-walled, enhancing, associated with fever, raised inflammatory markers, etc., can be aspirated. A hematoma, slightly dense on the non-contrast scan, and again, can be quite extensive, and heterogeneous appearance on ultrasound. So in conclusion, ladies and gentlemen, I would like to talk about the fact that diagnosis of groin hernias is a clinical diagnosis. For occult hernias or groin pain, MRI, particularly if it is a dynamic MRI in the prone position, for example, can be very, very good. And I think the current evidence supports it. Dynamic ultrasound or CT in the prone position can also be performed depending on local expertise. CT and MR imaging is excellent in differentiating between direct, indirect, and femoral hernias. And there are some changing clinical concepts regarding the pubic tubercle, as we talked about. And clinicians should be aware of normal and abnormal findings of a post-operative groin after a hernia repair. Thank you very much for your attention.
Thanks for that, Shuvro. We don't have a lot of time for questions, so we might just move on to David Chen, if we could load up his introduction slide.